So thank you, Mr. Chairman, and thank you for the organizer to the opportunity to be here by remote with you today. And my talk is on the new development, new therapeutic strategy is in hemoglobinopathy, in sickle cell and thalassemia, which is gene therapy. It's a long-awaited gene therapy. This is my agenda. This is an introduction as a gene therapy finally comes to clinical practice. I will report current result already published, and I focus my presentation on the result presented at the recent EBMT meeting in Paris, and finally a brief comment on the hardness of adoption of gene therapies as a widely used curative approach in hemoglobinopathies. Okay, gene therapy means in this we are talking about congenital disease, and in this case, gene therapy is based on the transfer of a therapeutic or working gene into somatic cell of the individual in order to repair a defective gene copy. This is may use to replace a faculty gene or to introduce a new gene whose function is to cure or sometimes partly modify the clinical course of the condition. So the message is it's not simply necessary to correct the disease, the gene, the non-functioning gene, but it's necessary to have a clinical benefit for the patient. Sorry. Okay, excuse me. Okay, in this condition, which is a congenital disease, what are the key to success of a gene therapy? As an high-titer vector and the efficient transfer into target cells. We are talking here of stem cells with an efficient engraftment of the traducer cell and the maintenance of stemness. This is a different issue than the CAR T cells. And we need an adequate persistent level of expression of this transgene, and we need to prove clinical benefit, correction of the disease in all its aspects. We see this particularly for what regards sickle cell, and of course, safety. The story is very long. It comes from a very long time. And the gene therapy is a natural prosecution of allogeneic transplantation in this form of the disease. And the story comes from several decades with a lot of improvement, but even several failures. The most important failure of the problem of this strategy was registered almost 25 years ago in a patient treated for primary immunodeficiency, in which in those patients it was registered a huge number of leukemia due to the vector. Following this event, which were regularly reported in the scientific literature, a lot of research have been done to correct this problem. It has led to the generation of much safer targeted vectors, such as self-inactivating gamma retroviral or lentiviral vectors. And there are also several studies, several research. The most important of them are reported here, which demonstrate safety and potential improved efficacy of this novel curative approach in hemoglobinopathies. But what is important to understand in this context that in this case of congenital inherited disease, the gene transfer has to be done in the hematopoietic stem cell, but the expression of the transfer gene has to be explained its efficacy just in the erythroid system and not in the other system. So we have talked about CAR T cell. In CAR T cell, it has to be modified the mature T lymphocyte. In this case, the modification is inside the stem cell, the hematopoietic stem cell, but its expression is just in the erythroid system. That's the two major diseases of transfusion-dependent thalassemia and sickle cell disease. So in this case, we need the gene therapy can have must prove to make a correction of the disease and to make clinical benefit. What does it mean? In thalassemia, and this is different from thalassemia from sickle. In thalassemia, gene therapy has to cause adequate production of beta or gamma globin This is to reduce globin chain imbalance, is the key of the pathology of thalassemia, and to obtain normal to have a normal transfusion dependence of hemoglobin, normal hemoglobin, of hemoglobin, fetal hemoglobin. So to obtain the clinical benefit is obtain transfusion independence, but this is not enough. The patient has to have shown absence of ineffective erythropoiesis and stigmata of ineffective erythropoiesis, so to have a very real, clear clinical benefit. This is different in the situation in sickle. In sickle, gene therapy must obtain at the same time adequate production of beta or gamma globin, and subsequently normal adult hemoglobin or fetal hemoglobin. And this hemoglobin must be able to dilute sickle hemoglobin at a not relevant clinical level, for example, like a sickle cell trait. And consequently, the clinical benefit must be absence of venous occlusive crisis and other sickle cell stigmata, which are more general than single venous occlusive crisis. There have been developed two different potential methods for permanently modifying hematopoietic stem cells. The first is gene addition. This is done using viral vector and consists in adding a copy, in this case, of beta globin gene. For example, we will talk of the gene able to produce hemoglobin AT87Q. Second method is genome editing. This is done using a gene reprogrammable nucleases, not a viral vector. And this method consists in generating a de novo mutation that result in persistence of fetal hemoglobin in the adult life. So the first published clinical evidence of benefit of gene insertion using Betty cell has been recently published by Franco Locatelli in the New England Journal of Medicine. 23 patients were consistent in the trial, 22 were presented, and transfusion independence was obtained in 20 of 22. This with patients with non-beta 0 beta thalassemia, transfusion-dependent thalassemia. Average hemoglobin obtained in this patient was almost 12 grams per deciliter of total hemoglobin, and a large part of this hemoglobin, almost 9 grams per deciliter, was constituted by the hemoglobin produced by the gene inserted inside the cell, and this patient obtained transfusion independence. And the methodology is, this is an ex vivo gene therapy, so it's require a mobilization of the cell done by GCSF and plerixafor, apheresis, central manufacture with insertion, return to the cell, modified cell to the center, a busulfan myeloablative regimen conditioning the patient without immunosuppression. This is just like on the clinical course is autologous transplantation, product infusion, and follow-up, even long-term follow-up. This is the result published in this paper in this category group of patients. On the bottom of this slide, you can see a graph reporting in blue line the total hemoglobin of this patient, and in the red line the hemoglobin produced by the inserted gene, and the patient presented transfusion independence. This is the result of the study. The published study demonstrated efficacy of this kind of gene therapy. In the latter graph, you can see median percentage of lentiviral vector positive cell in the Betty cell, and in the bottom of the slide, the vector coupling number in the Betty cell at 6 months after transplantation. These results were obtained in the first published trial in non-beta 0 beta 0 thalassemia, but after a modified manufacturing, same result have been obtained even in beta 0 thalassemia. Really important on the clinical point of view, as shown in this slide. But this patient demonstrated an absence of very limited and ineffective erythropoiesis, as demonstrated by soluble transferrin receptor, which is a marker of ineffective erythropoiesis in patients who would acquire transfusion independence. So these patients were really cured of their disease, and the same effect as can be demonstrated by this slide showing on the left a bone marrow patient before the procedure with clear sign of a very large expanded erythroid system with a sign of an affected erythropoiesis and almost normal marrow 12 months later, and the same effect of suppression of ineffective erythropoiesis demonstrated on the right part of the slide by the ratio between the myeloid and erythroid ratio, even at the same time 12 months after gene therapy. The second approach, and I will focus on this approach because this approach has been presented by Franco Locatelli at the recent EBMT meeting in Paris, is the gene editing. Gene editing is based on the clinical impact of gene editing is based on two clinical observations. The first is the hemoglobin switch, which happens a few months after birth. In the fetus, the hemoglobin is fetal hemoglobin. It's constituted by alpha and gamma chains, alpha 2, gamma 2, which became, and early after birth, production of gamma cell is suppressed and upper production of beta cell, leading to the adult hemoglobin, which is alpha 2, beta 2. The second observation is that clinical observation is that patients with thalassemia who present at the same time hereditary persistent hemoglobin F seen into adulthood present a less severe disease without any detrimental effect. So which means that fetal hemoglobin, even in adult life, is a good hemoglobin able to guarantee a normal life. So the approach is obtained by gene editing is disruption of the erythroid enhancer region of the BCL11A, which this disruption lead to the re-expression of the gamma globin and the production of hemoglobin F. So this the destruction, the suppression, permitting the persistence of the production, the reappearance in this case of the production of hemoglobin F. Even in this case, this is an ex vivo procedure, require mobilization. Mobilization in sickle cell disease is obtained at the same time with GCSF and Prerixafor. It requires apheresis, central manufacturing by CRISPR-Cas9 modification, return to the center, a myeloablative regimen. Even in this case, this is like an autologous transplantation, infusion, and follow-up. The trial is called CLIMB trial, Thalassemia 111 trial. At the recent EBMT meeting, have been presented 44 thalassemia patients. Mean age was 21 years, and the range was 12 to 35. On the right part of the slide, you can see the drug product cell dose, which was 7.5, and then the time to necrophil and platelet engraftment, which was 29, respectively 29 and 43 days. So the recovery of polyps and the recovery of platelets is longer than in traditional hematopoietic cell transplantation, but even in this case, long-term recovery is completely. In data presented at the follow-up of 1 year. And most important in gene therapy is safety. You see the adverse event reported in these 44 patients, mostly were related to the myeloablation of the conditioning regimen. All of them are very well-known adverse event. There was particularly related to extracellular, the product was a case of hemophagocytosis with characterized by macrophage activation syndrome, acute respiratory distress syndrome, headache, and interstitial pneumonia, all in the same patients. All this adverse event began pre-engraftment during the aplasia, and occur in the context of hemophagocytosis, which was the start of the whole problem. Because all the events fully recovered with steroid and immunosuppressant treatment. One patient with thalassemia presented adverse event related to XSL and bisulfite was delayed neutrophil engraftment and prolonged thrombocytopenia. Even in this case, the adverse event fully recovered with the follow-up. Even the result, you can see in dark blue the level of hemoglobin F produced during the follow-up. You can see by starting from the second month, almost all these patients presented transfusion independence, and a large part of their hemoglobin was hemoglobin F produced by the transduced stem cells. And if you look at clinical benefit, the transfusion independence, when you see that 42 of the 44 patients with more than 90% stopped at the red blood cell transfusion, and acquired transfusion independence. At the time of this analysis, 2 patients had not yet completely stopped the transfusion requirements. You can see with really important, we look at the cell, we can see that it was demonstrated the pancellular expression of hemoglobin F. And if you look at editing BCL11A, editing bone marrow on the left and the peripheral blood on the right, you can see that after the third period, there was a very stable editing of the BCL11A. And if we look at sickle cell, as regards the sickle cell, Professor Locatelli presented 31 patients treated with this approach. Mean age was 22 years and the age range was 12 to 34. All of them had severely symptomatic sickle cell disease. In this case, cell product was less than in thalassemia. We will see later the reason was 4. And even as in thalassemia, neutrophil and platelet recovery was a little delayed, less than in thalassemia, was 27 days for neutrophils and 32 days for platelet. The duration of follow-up for sickle, mean duration of follow-up for sickle was 10 months. Even in this case, this is an ex vivo gene therapy requiring mobilization, and in this case, mobilization is done only with plerixafor because of the risk of venous occlusive event with the use of growth factor, and this is the reason of the less number of obtained transduced CD34 positive cell. Even in this case, there is the apheresis, central manufacturing, a return to the center, and even in this case, a myeloablative regimen with busulfan infusion and follow-up. Important to look at the primary endpoint of this trial, and the primary endpoint as regard efficacy was proportion of participants who had not experienced any severe venous occlusive event, venous occlusive crisis, for at least 12 months. This is in the study, starting from day 60 after last red blood cell transfusion up to 24 months after product infusion. Then you see as a primary endpoint the safety endpoint. Of course, there were several secondary endpoints, but we just focus on the primary endpoint during this presentation. As regards adverse event, even in this case, a large part of almost all the adverse events were related to conditioning regimen, which was the same than in transfusion-dependent thalassemia, and safety profile was clearly consistent with the myeloablative conditioning and autologous stem cell transplantation. As to be reported that in this trial, 1 patient have died but severe respiratory failure due to COVID infection several months after product infusion. It was a not vaccinated patient. Investigator define this adverse event not related to XHL infusion, to XHL product. If you look at the clinical result, you can see the early couple of months, 3 months after the product infusion, there is a clear production of fetal hemoglobin that contributed to almost 50% to the total hemoglobin of these patients. So there was a successful engraftment with the production hemoglobin, fetal hemoglobin. And if we look what this was the primary endpoint, the clinical primary endpoint of this trial for regards sickle cell anemia, which is all the 31 patients at the data analysis of this part of the trial. All of the 31 patients presented were venous occlusive crisis free during the follow-up, of 1 year from 2 to 32 months. Clearly longer follow-up, a completion of the trial is necessary before a definitive conclusion. Even in this case, hemoglobin, production of hemoglobin F was pancellular, and even in this case, BCL11A editing was stable and consistent in all the cells, in bone marrow and peripheral blood cells. I want to conclude my talk just discussing very briefly with you what I consider this is very extraordinary result. We consider the hardest to wider development, wider diffusion of this curative approach, which is long-term adverse event, which of course require longer follow-up and pricing problem of the cost. It should be mentioned that inside the gene insertion program, the gene insertion and the gene editing program, have been registered 2 cases of acute myeloid leukemia. Initially, there were 3 cases, but following investigation, 1 case was considered not related to the procedure, but related to a pre-existing patient situation, where there were 2 patients of acute myeloid leukemia. In 1 case, the vector was not found inside the blood cell. But in the second case, patient 3, the vector was found inside the blast cell. Further investigation led to the conclusion that there was not causative this insertion, that the program was restarted. And we have to, it's an important consideration, these events were registered just in sickle cell disease and not in thalassemia. And we can see that sickle cell patients present at a higher risk compared to normal population of acute leukemia, even if the incidence is less than was reported in the few cases of gene therapy in this disease. There is a large California study and a large UK study reported the risk of acute leukemia, acute myeloid leukemia in this category of patients. Clearly, in my opinion, is that further investigation are necessary in this field, particularly in the field of sickle cell, just to define the main risk factor. Should be so I think that should be investigated increased inflammatory condition that presents in this category of patient, eventually relationship with the conditioning regimen or the preconditioning regimen of the pre-gene therapy or with the gene therapy itself. That clearly more investigation are necessary. The second problem is what is called financial toxicity. This is clearly an expensive procedure, and value probably is clearly defined by cost and price has to be clearly defined. It has to be reported that in 2021, after approval by HEMA, and this was regarding gene insertion, there was a lack of economic agreement between the manufacturing company of the gene insertion program and the German regulatory authority. Germany is the first country in Europe that can have commercial authorization after EMA approval. And this lack of agreement led to closure of the company activities in the European Union, with consequent not availability of the product in Europe. At the bottom of the slide, you can see the official press release by ASH. This is clearly a problem. At the moment, I have not information about possible cost of the gene editing product. Finally, I want to make a comment. These are fantastic products. It is a fantastic step forward in our possibility to cure hemoglobinopathies. Hemoglobinopathy is a congenital disease, and the proof of the possibility to cure the disease has been done by hematopoietic stem cell transplantation several years ago. But sometimes people and patients can believe that medicine are enough, but for this reason, I want to remember this statement by Dr. Carl Gustav Jung: the medicine can cure disease, but only doctors can cure patient. And with this remembrance, I thank you for your kind attention.